So on average, what is the incidence rate of patients who have erectile dysfunction or pelvic pain that is related to back problems?
Oh, that's a lot. The more we explore, the more we feel there's definitely at least half from my experience. At least 40 to 50% of patients have pelvic pain, and the pain will resolve quickly by treating the back. So that's identified as a spinal source. So it's definitely a lot, not only just the pain, urinary dysfunctions, urgency frequencies, constipation, sexual dysfunction, many can resolve quickly with their with repeated spinal exercises.
That's very interesting. So could you just quickly walk us through your process of assessment, and then how? So what you always test the spine first? Do you follow the same rationale? So first you exclude the spine, and then you go to the other route. So how does that work in your practice?
Yeah, I think the same process as treating the extremity per se, use MDT principle. The key point, you always have to establish a good baseline. This baseline can be pain, and many pelvic symptoms can be established as a baseline. And you always go through, rule out the spine first, and then you move down. You can do abdominal pelvic testing and try to rule out whether there is dysfunction, dysfunction such as contractile dysfunction, and there's percentage of articular dysfunction happening in the coccygeal joint. And then if it's not falling to the two category, you can further, classify it as other subgroups. So we do see similar presentations as peripheral nerve entrapment, such as pudendal nerve. We definitely see chronic pain syndrome because there's many psychosocial influences. MURs, it's like there are some patients have this sacral neuropathy and have all these neural symptoms, change of sensation, change of muscle contraction. We definitely also have mechanical inconclusive. Many things we see in the extremity exactly we can see from the pelvic population.
And I'm curious to know, how do you manage dysfunction? Either contractile and do you have articular too? So, and how are your pelvic floor tests and procedures? Because I remember about your webinar that you put it there loaded and loaded, and then active and passive and resistant. So how does this test works, and how about the dysfunction?
Okay, so for dysfunction is similar to we treat a contractile dysfunction for the extremity. So basically you have to identify what kind of a loading can produce their symptom and follow the same pattern as produce no worse. So that's why, sometimes the pelvic pain, they may not be produced while in lying. So if that's the case, you do give someone exercise just lying down there and contract, relax. You may not have the effect you want. So patient may have more loading in terms of sitting or standing, or either with some other activities. But your goal is always try to produce the pain but no worse, and follow the loading strategy to the pelvic, the tissue. And some may change quite quickly if that's the contractile dysfunction coming from the muscular fibers. They may adapt quickly. And if from tendon junction, they may have to load it a bit longer. So, but the same principle, you explain to the patient, you see that when you do it, this is produce your pain and produce, just follow the treatment, produce no worse. And they understand that. And normally after a certain amount of loading times, and the symptom will start to change and tissue will start to adapt. So yeah, sometimes we also use some definitely passive treatment sometimes. I mean, passive treatment in terms of passive load, sometimes patients have to practice using insert something. For example, let's say I have a patient, he practice anal penetrative sex, receptive sex, and he has this pain actually due to scar tissues around the pelvic floor, which has happened in the past after unpleasant sexual intercourse. And for that, you really have to help him, we use different insertion equipment and desensitize tissue and load the tissue and gradually the tissue adapt. So yeah, so similar to the extremity, it just you have to be targeting the tissue you want to load for dysfunction.